Bismillahirrahmanirrahim. Hello guys, and today we are going to discuss another topic of the renal disorders that we term as nephrotic and the nephritic syndrome. So basically what is the difference between the two is that the nephrotic syndrome is more kind of protein leakage disorder and nephritic syndrome is like inflammation in the glomeruli, and both of the disorders are very different from each other, but nephrotic syndrome can develop into nephritic syndrome. Like, it's a broad term. The terminologies that are included in the nephrotic syndrome we study, first of all, it's the focal segmental glomerulosclerosis. I'm just briefing the overline of the nephrotic syndrome, FSGS. Then we study the minimal change disease in this. Then comes the membranous nephropathy or membranous glomerulopathy, if you want to say it like that, okay? And other systemic diseases like amyloidosis. Amyloidosis is also included in the nephrotic syndrome because amyloidosis can damage the kidneys. The next is the systemic lupus erythematosus that we call as lupus nephritis. Last but not the least is the diabetic nephropathy. So this is the overview of the nephrotic syndrome, what we study, the diseases that are included in the nephrotic syndrome. So first of all, in the today's lecture, we are not going to discuss about these details, but we will going to start with the introduction of the nephrotic syndrome. What is nephrotic syndrome? What are the essentials to diagnose the nephrotic syndrome, and etc. First of all, we will talk about the essentials to diagnose the nephrotic syndrome. Essentials to diagnose the nephrotic syndrome. Okay, nephrotic syndrome. So first of all, in the nephrotic syndrome, we can see massive proteinuria. It's the number one essential to diagnose that. In nephrotic syndrome, there is a huge amount of protein loss, massive protein loss, or massive proteinuria, if you will, right? Why is that so? Why is massive proteinuria occur in the nephrotic syndrome? Because nephrotic syndrome is a disorder of the podocytopathy. What does it mean? Podocyte damage. Due to some cytokines, chemokines, and lymphokines, the podocyte are going to be damaged, and that's why we are gonna see massive proteinuria, massive lipiduria, etc. If the podocytes are damaged, the filtration barrier is going to be disrupted, right? Charge barrier. The glomerular basement membrane and the filtration barrier contains a negative charge, but due to the disturbance of the podocyte, this negative charge is neutralized. Neutralized. It means that it's not gonna work as the filtration barrier anymore, and it will gonna allow proteins and other small molecules, like we can say albumins and other lipids, to pass into the urine. This is the main, like you can say, pathophysiology behind that. Massive proteinuria, what is the we can just term it as massive proteinuria, but what is the exact number, or what is the exact amount of the massive proteinuria? It's more than 3.5 grams per 24-hour urine. Right? We ask the patient to collect his or her 24-hour urine, and in that massive amount of urine collection, we will see more than 3.5 grams of protein per 24 hour. But you know that this collection is very not very easy for the patient as well as for the doctor as well. There is the chances of under collection, or there may be chances of over collection if we do not guide the patient properly. So there is a technique. Despite of 24-hour urine collection, we can have a spot sample. We can check the protein in a spot sample. What does it mean? It means that in one sample, In one sample, we can calculate the amount of protein and we can term that this is very high proteinuria and we can suggest that it's nephrotic syndrome. So in spot sample, if the urine protein is more than 2 grams of protein per gram of the urinary creatinine, per gram of urinary creatinine, it's not serum creatinine, it's urinary creatinine. This is very important as per to diagnose the nephrotic syndrome. If the in the spot sample, we are not talking about 24-hour urine, but we're talking about a spot sample. If the spot sample has more than 2 grams of protein, of course in the urine, right? 2 grams of urinary protein per gram of the urinary creatinine, that we can term this as the nephrotic syndrome, right? So this is very convenient for the doctor as well as for the patient. Next is, first of all, we have discussed the massive proteinuria. The second is the hypoalbuminemia. Hypoalbuminemia. It means that the serum albumin is going to be decreased. Why is that so? Because the albumin is lost into the urine. So why not the serum albumin is low? Hypoalbuminemia is very suggestive of the nephrotic syndrome. But what is the amount? If the serum albumin is less than serum albumin is less than 2.5 milligram percent, okay, then we can suggest that this is the hypoalbuminemic state if it's less than 2.5 milligram percent. But what is the normal range of albumin in the blood? It's 3.5 to 5.5, and albumin is a very essential protein to maintain the oncotic pressure, to prevent the edema component, like, right? So it holds the fluid in the circulation and it does not allow the fluid to enter into the tissue space. That's what we call edema. If the serum albumin is less than 2.5 milligram percent, so will the patient not have edema? Yes, he or she will going to have edema. The third component exactly is the decreased oncotic pressure, because albumin was holding the fluid into the circulation, so decreased oncotic pressure due to hypoalbuminemia. Decreased oncotic pressure, and this decreased oncotic pressure will contribute to the development of edema. And if a patient comes to you and he or she says that in the morning I have puffy eyes or I have periorbital edema, at the middle of the day I have like scrotal or genital or vulvar edema, and at the end of the day I have pedal edema, so you can think like she or he might have the nephrotic syndrome. So during the beginning of the day, the patient can have the puffy eyes or periorbital edema. Periorbital edema, because the fluid is lost into the tissue space. That's why periorbital edema. Then she or he can have genital edema. And at the end of the day, foot will going to swell. That's we call as the pedal edema. So these three edema component can be there. Or if a child presents to you with like her or his mother says that my child is having weight gain despite he or she is not eating enough food, but he is looking puffy, right? So we can suggest that there is edema component there. These three are the essentials. First is the massive proteinuria, hypoalbuminemia, and decreased oncotic pressure. But there are, of course, some other features related to the nephrotic syndrome. The next feature is hyperlipidemia. Hyperlipidemia. Hyperlipidemia, why is that so? Why the lipids are increasing in the blood? Liver synthesize albumin and liver also synthesize lipoproteins like LDL, HDL, VLDL. So if the albumin is going to decrease, to compensate there will be increased hepatic lipogenesis. Increased hepatic lipogenesis, okay? Liver starts to produce more lipids to compensate for the loss of albumin. Increased hepatic lipogenesis. So if in a patient the lipids are going to increase, what are the complications? First of all, the triglyceride is going to increase. The patient can have hypercholesterolemia. Mm, okay. And the next thing, the patient can have increased chances of atherosclerosis, because atherosclerotic plaques are formed by the lipids, right? So atherosclerosis chances are going to be increased in the patient of the nephrotic syndrome. But this atherosclerosis is not peculiar to the nephrotic syndrome. There are other conditions in which we can see increased atherosclerosis. First condition is that we can see increased atherosclerosis in systemic lupus erythematosus. In SLE, there can be increased lipid in the blood. Diabetes mellitus is a very important condition that can lead to increased atherosclerosis. The third condition is hypothyroidism. Okay, hypothyroidism is not like very important, but yes, we are talking about increased atherosclerosis, so why not we can mention hypothyroidism as well. The next condition is that the syndrome X, it is a syndrome in which there is increased atherosclerosis, syndrome X. Okay, and the last but not the least is APLAS. What is APLAS? I'm not going to write the full abbreviation here, but it's antiphospholipid A syndrome. Okay, it's antiphospholipid A antibody syndrome. These all conditions can also contribute to the development of atherosclerosis. So if a patient comes to you with high chances of atherosclerosis, it's not peculiar for the nephrotic syndrome. They might have other conditions, right? So next thing, which is the other feature of nephrotic syndrome, we can include lipiduria, because increased lipid production will cause increased lipid excretion as well. So lipiduria is also present, but lipiduria is not only specific to the nephrotic syndrome. Lipiduria might be included in the filariasis syndrome. Filariasis, it's a parasitic infection. Filariasis syndrome, it's a parasitic infection, or lipiduria can be included in the fat embolism syndrome. Fat embolism syndrome, right? After the lipiduria, under the urine microscope, if the lipids are being present in the urine, what does the microscopic examination tells us? It will tell us the presence of oval fat bodies. Oval fat bodies are seen in the urine of the nephrotic syndrome patients. Oval fat bodies, and other thing is seen as Maltese cross appearance. Maltese cross appearance, it is suggestive of the lipiduria. Maltese cross appearance, okay. Oval fat bodies are seen under the light microscope, and the Maltese cross appearance is seen under the polarized light, okay. But Maltese cross appearance is also seen in other conditions. For example, if it is present in the urine, it can be due to Fabry's disease, that is the lysosomal storage disorder, that's we are going to discuss later. But just for now, you can remember Maltese cross appearance is also present in the urine of the nephrotic syndrome patients. The next thing is that these patients will have hypercoagulable state. Hypercoagulable state. Hypercoagulable state means that the blood tendency to clot will increase. But why? Because there is the urinary loss of antithrombin 3. The urinary loss of antithrombin 3 and other anticoagulants will increase the blood tendency to clot more rapidly. Antithrombin 3 is lost into the urine. That's why the patient starts to develop hypercoagulable state. But what is included in that? Like for example, there can be deep vein thrombosis, and the complication of deep vein thrombosis is pulmonary embolism. The next, it can develop, he or she can develop renal vein thrombosis, right? So these conditions are very dangerous. They can be due to antithrombin loss, antithrombin 3 loss. As we note that the anticoagulant is very important. Anticoagulant system is very important to prevent the blood to form clots unnecessarily. So anticoagulants are, as I have mentioned, antithrombin 3, as well as there are other proteins known as the protein C and protein S. So protein C and protein S are the anticoagulants of our anticoagulant coagulant system. And coagulant, as you know, that thrombin is a coagulant, fibrinogen or fibrin is a very powerful coagulant, as well as the platelets, right? So the balance between the anticoagulants and coagulants is very important to maintain the blood consistency. So, one more thing just for an extra edge is that the protein C is converted into the activated protein C, and this activated protein C will going to degenerate the clotting factors. Activated protein C is going to degrade the clotting factors. And what type of clotting factors we have? Clotting factor 5. Okay, we can have the clotting factor 5. So this protein will going to degrade the clotting factor, and that's why it is preventing the coagulation. But what is the molecule that converts protein C into activated protein C? It's thrombin. Okay, it's fibrinogen, to be more accurate. Fibrinogen converts protein C into activated protein C, and it's going to degrade the clotting factors like clotting factor 5, and it's going to prevent the coagulation. The next thing is that these patients will gonna leak ferritin into the urine, and ferritin is iron, right? So these patients will have anemia component in them. The nephrotic syndrome patients, right? Anemia component will be there. The next thing lost into the urine is known as ceruloplasmin. Ceruloplasmin is very important in copper transport, okay? And ceruloplasmin, it is also an acute phase reactant. It is very activated in the beginning of the inflammation, right? So ceruloplasmin is also lost into the urine, so copper transportation is also hindered in this way. The next thing is that the deficiency of ferritin cause anemia, the ceruloplasmin loss into the urine. The other thing is that if there is factor 5 Leiden mutation, we have discussed factor 5 here. Factor 5 Leiden mutation. So, what does it mean? The factor 5 is gonna activated, like it has mutation, so it will gonna be activated. It's not activated normally, it is hyperactivated, so the patient will have thrombophobia means that increased amount of platelets inside the bloodstream. So platelets causes the blood coagulation, so clotting time is decreased, clotting will be more, and it can have complications like renal vein thrombosis, pulmonary embolism, and the deep venous thrombosis. So this is due to the factor 5 Leiden mutation. It's hyperactivated in this condition. So this is for the nephrotic syndrome. In the next lecture, we are going to discuss about the focal segmental glomerulo-sclerosis, and we are going to discuss about this condition, and after in the subsequent lectures we are going to cover these all diseases. So thank you for watching, and I will see you in the next